Hi guys, this is Charles. I'm one of the surgeons at the Animal Emergency Center in Melbourne, Australia. Today we have a small dog, about 10 kilos, who has presented with a cruciate ligament rupture. We can see the cranial drawer instability right there. And so we discussed options including TPLO and extracapsular suture, and the owner, for financial reasons, has decided on the extra cap. And so that's what we're doing. We don't do a lot of these, but I thought it was a really good example of a case that you guys could see and maybe use some hints and tricks that I have come up with over the years to make these go a little bit better. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So when we look at the anatomy here, we've got the patella and the tibial crest. Oh, probably going to get a question about why I'm using IABAN on this case and not on other cases. And the reason is that I'm using a braided polyester suture, Liga fiber, and that has a relatively high chance of getting infected. And so I'm using the IABAN to protect the Liga fiber from getting contaminated with skin flora. So my incision is going to go from a third above this distance through the tibial crest and then down almost another third distally. So it's kind of a third, and a third, centered on the distance between the tibial crest and the patella. Now, even using off-site spray, the IABAN hasn't stuck completely.
Do you need a suture for the skin edge?
No, that's all right. So I'm doing a lateral parapatellar approach. I might move the camera a little bit so you can see what's going on. All right. Dog's waking up. So we just need a minute for the dog to go back under. We have done a femoral and sciatic nerve block, but that can take about 30 to 40 minutes to take effect. Yeah, that's great. Hi, Argentina. Hi, UAE. So there's the patellar tendon sitting right there. So I'm going to go just immediately lateral to the patellar tendon. And I always enter the joint on any cruciate ligament repair, because I always want to check that meniscus. And I know that that is not a universal opinion, but I feel like the risk of leaving a damaged meniscus in there makes it worthwhile going in and having a look, because if you leave a damaged meniscus, reasonable chance that you're going to get an inferior outcome. All right, so we've got our ruptured ligament right there. I've got my sen retractor here. So we're assessing the cruciate ligament, which is completely ruptured. Right there. Let me just see what the meniscus looks like. So I'll get my Homan retractor and see if I can get that back there. All right, so hold on to that. Now that is a really good view of an intact meniscus for you. All right, so that's a beautiful view of that intact meniscus, and what you can see there is the caudal meniscotibial ligament right there. All right, so I'm just kind of poking around with it. Use a hemostat to make sure that the caudal pole does not slide forward. I'll get up underneath that caudal meniscal tibial ligament to try to displace it cranially. That is all completely intact. Can I get some saline, please? So that meniscus is intact. All right, so that's it for the intra-articular portion. I can trim a bit of that old ligament out. All right, so we'll just get a little bit of flush. Some 2O PDS, please. Take that out, yeah. We'll take out our Gelpy. Now, when I do this part of the closure, and I do want to do this as soon as I can because I'm trying to avoid contamination of the joint and resulting septic arthritis. So what I'm going to do is I'm just going to close the joint capsule itself because I'm going to have to get behind that fabella. So I can't close the whole fascia lata, but I can close my joint capsule to reduce the time of exposure of the joint. Okay. So arthroscopy is generally better. It does improve outcome and quicker recovery in dogs. This is just quite a small dog is the reason why I haven't done arthroscopy. But if you can do arthroscopy and you have the equipment and the skill, I think that you'd be better off probably doing arthroscopy. Actually, because it's such a small dog, I didn't even think about doing arthroscopy here. I probably could have done it. I mean, it was probably big enough for me to get in there. So I'm just closing joint capsule. I'm leaving my fascia lata unclosed, and I'll go back and close that later. A little bit of annoying bleeding from that infrapatellar fat pad. All right, so now what we have to do is lift up that fascia lata using a medicine bomb. So you can set that down there. All right, so I'm going to lift up the fascia lata and I'm going to dissect down. Like that. And then we'll get a Sen retractor back here. So you can let that drop. So that's vastus lateralis right there. And then we should be able to palpate the fabella. Let me just open this up a little bit more. Remember, the fabella is a sesamoid for the gastroc. All right, so my fabella is right here. You can't see it, but you can definitely feel it. I might just expose this a little bit more. We'll come a little bit farther distal here. All right, so that's my fabella right there. So you can see it kind of poking through right there. All right, so I need to get my ligafiber. Ligafiber, please. And so that's gastroc muscle right back here, and so that's the femorophabellar ligament. Maybe can expose that a little bit more. A little better view of the fabella. All right, so we're getting our ligafiber out. And this ligafiber has needles swedged on. So that's our ligafiber there. So I need to pass the needle around the fabella and hopefully through the femorophabellar ligament. So I'm definitely around the back of the fabella, and this can be one of the harder parts of this surgery, is actually getting it around that fabella. That's going actually into the fabella. Okay, so that's around the back of the fabella there. Let's move that forward a little bit. So that's around the back of the fabella. Okay, and the way that I can tell is that when I pull on the string, you can see that there's still a gap between the two strands. Okay, if I was just in soft tissue, the two strands would come back together like that. But since they're separated, it means that I have to be around that fabella. And I could basically swing the dog around the room. All right, and I see that there's some questions, and I will have to come back and answer those in a minute. All right, so now what I'm going to do is I'm going to take this needle and pass it underneath the patellar tendon. Okay, so that's underneath the patellar tendon. And then when we make our hole in the tibial crest, there's a tendency for people to make the hole way too far distal. Okay, the center of rotation from the fabella is right about there. So just underneath the tibial, or just underneath the tibial plateau. So I'm just cutting away the cranial tibial muscle here. All right, and then we'll get a inferior elevator. I'm just going to peel that cranial tibial muscle back. Okay, so my tibial plateau is here. I want to go immediately underneath the tibial plateau. My favorite way to do this is with a 14 gauge needle, but we don't have any. All right, so I'm going to go just underneath the tibial plateau. And quite far caudal, so it's just in front of the extensor groove. Okay, just like that. See how far proximal that is? So that's my tibial crest there, so I'm actually above the attachment. All right, and then we just need to find our hole on the other side. Just poke it through here. Okay, so it's all the way up there. Now I'm in the right hole. Okay, so that's through the hole there. You can let that down. All right, and then it's going to tie it like this. You don't want to go crazy tight. You just want the leg in a fairly physiological position. Let's just see how that goes. Yep, so that's pretty solid. I could actually go a little bit tighter. Okay, so that's really solid. All right, and then you can't cut this suture with scissors. You have to use a blade. It's too stiff. Okay, so that's our repair there. All right, so now let's check our stability. Really good. And range of motion, if you put your sutures in the center of rotation, it shouldn't affect your range of motion at all. Okay, so let's remove that. Do a little bit of a flush. And then I'm going to do a few little interrupted or cruciate sutures. Just to give me a little bit of imbrication. I will go back and try to answer all the questions when I'm finished with my portion of the surgery, and Cindy has taken over. So the key thing with doing an extracapsular suture is drilling your hole in the proximal tibia quite far proximal, right underneath the tibial plateau and just in front of the extensor groove. I can see one question. I don't have any experience with the orthostay system. And I'll be honest, I'm not really on top of all that stuff because I so infrequently do extracapsular sutures. I'm almost always doing TPLOs. Let me get some 3.0 PDS, please. Okay. All right, so our next layer is this genicular fascia, which is right there. All right, so we're going to close that over to that, and then just an intradermal layer. All right, so, and that was a square knot that I put the rate of meniscal tear damage with extracapsular is probably somewhere around 10%. With TPLO, it's about 3%, and with TTA, it's about 35%. So I'm just going to go back and make sure there aren't any questions that I haven't answered. I do use the same extracapsular repair when I combine with a tibial tuberosity transposition. Placing suture around the fabella and then partially through the distal patellar ligament close to the attachment. I would be concerned about that, Hamilton 552, because I think that putting too much stress on that, you could potentially pull through that distal patellar tendon. And so my preference would be to drill it through a hole in the proximal tibial crest. So I've got a bowl, a sterile bowl that comes in all of my surgery kits, and that's what I use here. Actually, I'll move my camera so you can see what's on my back table. So that's my sterile bowl right there, and it comes in my surgery kits. And so I just have my nurse fill that up with saline. And then that's what we use for sterile flush. Let's see here, gone right wide angle there. All right, so I'm just going back to questions. So TPLO is superior to lateral suture because there have been studies that have shown that the recovery from TPLO surgery is quicker and more complete than with extracapsular suture. Also, there was one study that showed that there was significantly more severe arthritis with extracapsular suture than with TPLO, particularly in larger breed dogs. So Yeah, so I definitely prefer it in larger dogs, and in fact, I prefer it in all size dogs, larger dogs. I prefer it in all size dogs, but this case, for financial reasons, they decided to do an extra cap. Hi, Snowy Netherlands. Patient history is acute onset of hind limb lameness about 2 to 3 weeks ago after jumping. No previous history of lameness. And then on radiographs, there was a fusion in the stifle and then cranial jaw instability. Hi, Colombia. Hi, Indiana. Hi, Dominican Republic. Hi, United Arab Emirates. And hi, Argentina. All right, back down to the bottom. So can you thread the suture under the femorfabella ligament and also under the lateral collateral ligament? No, I would not do that, because the direction of pull of the cranial cruciate ligament is from caudal on the femur to cranial on the tibia. If you go through the collateral ligament, that's actually quite far distal to where you want that suture passing. So the collateral ligament is not, you would not want to go around the head of the collateral ligament. So with most cruciate ligament repairs, they should be ambulatory within a couple of weeks after surgery and improving from there. So if I had one that was not doing that, even like if I have a dog that's not weight bearing by 2 weeks out from surgery, you might try physiotherapy, but I would be pretty concerned. If it's an extracapsular suture, that can be due to entrapment of too much soft tissue in your fabellar suture, and so I would check for pain around the fabella. And if there's pain around the fabella, I would probably try to get them out 2 to 3 months from the surgery and then remove the suture, because the scar tissue will have formed. Other possibility would be infection, so make sure that they're not infected and that there isn't any swelling down the leg. Other possibility would be meniscal injury. With TPLO, if they're not ambulatory at that time frame, I would worry about infection, rejection from the plate, maybe patellar desmitis, and you should be able to see that on a radiograph. And meniscal injury would be the other possibility. So there's a question about doing 2 holes in the tibial crest instead to avoid going under the patellar tendon. I don't have any problem going under the patellar tendon, so that's how I've always done them. I have seen people drill 2 holes, but it might be maybe a little challenging to get them close enough together to get your proper positioning of that suture. And so that's why I like using a single one, because you can put that suture hole exactly where you want it. Infection rate of TPLO is somewhere between 2.5% to 5%. Yeah, so that's kind of what I see. Question, I think revising the question from before Hamilton 552, this is a dog that's not doing well a few months after cruciate ligament repair, and the tear was already old when they got in there. I guess I would look at the amount of degenerative joint disease at the time. And if there was already a lot of DJD, you might lower your expectations a little bit, but I still find that with the TPLO, even with an old tear, once you change the biomechanics of the joint and revise or improve or mitigate that tibial plateau angle, they still tend to do quite well. Extracapsular suture, you're probably not going to see quite as much improvement if it's an old tear. Hi, Philippines. All right, I think that's about it. So I'm going to wrap it up now. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. We'll see you again soon. Thanks again.